All right, then I think we will, thanks very much. I think we'll move on to the panel, the larger panel discussion.
Sure. Okay, and so I'd like to begin by introducing the additional panelists. And starting to Ruth's right is Rebecca Dresser, who is the Daniel Noyes Kirby Professor of Law and Professor of Ethics and Medicine at Washington University in St. Louis. Oh, you moved. Okay, let's see. Next is Donald Brunquell, who is the Director of the Office of Ethics for Children's Hospitals and Clinics of Minnesota. And next to him is John Tyson, who is the Michelle Bain Distinguished Professor of Medicine and Public Health at the University of Texas Health Science Center at Houston. And our final panelist is Cynthia Gagon, who is a patient advocate and principal of Patient and Partners, LLC. And so we'd like to begin the panel discussion by asking or offering to each of the panelists an opportunity to give their reactions to the presentations that you heard. Sure.
Hi, thank you. It's been a fascinating discussion. I thought I would throw another example into the mix, and this is something that really happened to me. I had cancer almost 9 years ago, and as part of my treatment, I was offered participation in a trial. I would say one takeaway from all this is one size does not fit all. I think we need to recognize that, like other forms of human research, standard of care research is variable, and probably we need case-by-case determination. So this is a medical versus medical trial, not medical versus surgery, but I still think it's a case where the prospective subject ought to hear about the risk presented by the two arms, even though they were standard of care. So the tumor board, in my situation, recommended a certain treatment approach. But then my physician is also a physician investigator and said, and there is this other option. And in that option, there would be two arms. One would get only what they call chemoradiotherapy, so that's one chemotherapy drug and radiation. The other option, they would get 3 chemotherapy drugs and chemoradiation. So obviously, the one arm would involve many more risks and burdens. On the theory, I believe that, and the hope that the less intense treatment would produce results similar to the more aggressive treatment, so the side effects and burdens would be less. So the comment that you don't just think about risks, you also think about expected benefits is very, I think, real. Now, if I had received a consent form saying, well, these are both standard of care and that they're both approaches used for people who have your kind of cancer, so they're, and you're going to be assigned to one or the other, and that's all I was told, and I wasn't told anything about the different risks of the different chemotherapy drugs I was going to get. I think that would have been unethical, and I would not have been able to make an informed choice. And there were definitely, different risks, probably in the one arm, greater risks, but also a trade-off for potential, higher benefit with the more intensive approach. And I needed to know all that in order to make a decision. Now, I ended up deciding not to be in the trial at all, which I won't talk about why, but actually I think I had a very good experience even with the treatment, because my doctor, who was a surgeon, said, well, we like to do surgery here. However, If I were talking to you on either coast or in Europe, we wouldn't even be talking about surgery. He was very open about the variation in the standard of care and the different risks and benefits. And I mean, I'm not just a rhetorically eloquent, I don't think I am a rhetorically eloquent patient, but I'm a real patient, and this is how it seemed to me. And I wanted that information, and I thought I should have gotten that information. So I have other things to say.
Okay, so I want to first start by recognizing some of the background here. I was happy to hear Nancy talk this morning about the non-comparability of clinical and research consent forms, because this is a major issue and becomes a problem for an IRB in evaluating the standard of care research. And it is important that we remember that researchers and treating physicians are often the same people. And so clarifying their roles becomes extremely important and also difficult. I want to mention the complexity of determining what a standard of care is. I did a little bit of background research. There is no definition. Differences between physicians in a group, differences between groups, differences between hospitals, differences between regions, differences between nation. And if we are going to try to talk about standard of care, we need some workable definition. I left out differences between specialty, surgical, medical, pulmonology, cardiology. All of these differences are very real. So I think we need to talk about perhaps not about standard of care, but alteration of usual care. Because when a patient comes to an institution, they are expecting to get the care. They want to believe desperately that their doctors are at least really good, if not the best. And their expectation is what is usually done, what is usually offered to most people. And to talk about standard of care, it changes the discussion. So as an IRB, what I might want to ask is, are you doing anything different than the usual care this patient would receive? I don't know if that helps us get away from some of the complexity of standard of care or just raises another set of issues. We need to think about how all these local IRBs are going to apply local standards of care to multi-site studies and what that does to the validity of multi-site studies, because we are, well, enough. So I wonder if the guidance, which I actually find very complex and difficult to understand, having read it quite a few times, but if it can provide some framework for evaluating usual care or standard of care, so that IRBs might approach it in a somewhat more similar way, rather than having each IRB decide what standard of care means. So I'd like to see some specification of the guidelines. And I just want to weigh in briefly on the debate on consent forms and should they be done away with. Now, consent forms are by no means enough in and of themselves, but as a guide to standardized work, they can be very useful. And without some kind of written guidance about what should be discussed, the consenting process will be way more variable than it currently is, which is already very variable. So I'll stop there.
Thank you. I see a lot of complex issues raised today. I want to first address one that I don't think has been raised, and that's the issue of competing outcomes, not necessarily being something that should be considered a research risk in comparative effectiveness research. So to illustrate, let's consider a hypothetical 5-year randomized trial of 2 drugs to reduce blindness among elderly patients with macular degeneration. And let's say that there was no evidence that that death would be higher in one group. No reason to expect that. However, it's clear that in this age group, death is going to be a competing outcome that will preclude the evaluation of whether or not the drug prevents blindness in some of the patients. So in that situation, for that reason, and to comply with the intention to treat principle that's recommended for clinical trials, the appropriate primary outcome is death or blindness. Any requirement to list any outcome as a treatment risk would mandate that you specify increased death as a risk for either of these drugs. And I will ask, wouldn't this really unduly discourage enrollment, mislead patients, and distract from more likely treatment risks? With respect to the potential or known risks of treatment and how they should be defined, my colleagues and I would propose something like treatment hazards that are either, one, biologically plausible, but not assessed in any well-performed clinical study, and there are various criteria out there for that, the GRADE criteria, the U.S. Preventive Task Force criteria, and that would ordinarily be in a randomized trial or at least a well-performed cohort study. Or two, that the risks would be significantly or at least marginally associated with the treatment, say a p less than 0.1 or 0.15. In the most recent systematic review, preferably one performed as part of the Cochrane collaboration of relevant randomized trials, or in the absence of such a review, the best of the available clinical studies. And I would contend that in legitimate comparative effectiveness research, that there would be minimal incremental risk from treatment, as it would not be known from a systematic review of the best available evidence. What treatment had carried greater risk? It would not be foreseeable what treatment had greater risk relative to the benefits. So to me, the central problem as a clinician, a clinical investigator, and somebody who helps direct quality improvement programs in our hospital, the central problem is really risk disclosure and consent for routine clinical practice rather than for comparative effectiveness research, and the double standard for using the same unproven therapy. Where Dr. Glantz sees blacks and whites, I see a lot of gray when we talk about the differences between clinicians and clinical investigators. There is much of clinical practice that is not driven by the physician's desire solely to improve the care of the patients. There's a lot done in clinical practice to try and learn as you go along, and who doesn't want a doctor that doesn't learn from his patients? Conversely, I see clinical investigators who work very, very hard to optimize the care of patients in their comparative effectiveness trials. This double standard for consent for the use of the same unproven therapy in practice and in clinical trials, doesn't this really violate the ethical principles of respect for persons and beneficence, highlight the need for to better assess what patients need and want in routine, urgent, and emergent circumstances, and promote routine clinical use of therapies over proper trials of unproven therapies? Sadly, partly for this reason, at best, only a third of the therapies that you and I get when we go to doctors are known to be beneficial or even likely to be beneficial. So this leads to these recurring episodes where widely used therapies are recommended by all kinds of official groups and then later discarded when they're shown to be harmful or ineffective. In neonatology, my specialty, this includes the routine resuscitation of asphyxiated term babies with 100% oxygen, a practice that was recommended for decades and that we now know is increased mortality. So to me, the central ethical challenge is to better serve the principles of beneficence and respect for persons, and better serve patient wants and needs, better meet those wants and needs whenever unproven therapies are used, whether it's clinical practice or comparative effectiveness research. Thank you.
Thank you. I have been called a lot of things, but I've never been called a rhetorically gifted patient. And it's interesting to try to define what a patient advocate is, and I'll give you a little bit more about my background because I'm also not a demonstration project. But I have been working for 20 years in this area, founding, counseling, supporting patients, serving as reviewers and investigator on some clinical trials. I reviewed a lot of protocols, and I could talk forever about what's wrong with informed consent, but I could also talk about what works and why patients participate in research. So on that note, I've been asked to look at what reasonably foreseeable risks to patients might look like, and that's quite the challenge. But I'd like to look at it a little bit more broadly and bring some things up I think that came up on this panel. If we, comparative effectiveness research and standard of care research, regardless of how it's defined, which is challenging, has never been more important than it is right now. And as these guidelines are reviewed and read, and I too had struggled with kind of definitely applying them and thinking about them. But what I view as a patient risk more globally are two things. One is we are reinforcing and delegating this type of research to organizations, platforms, and means that are not regulated by the common rule. And this comparative effectiveness research, I mentioned this morning, is already going on between payers, health systems, patient groups. It doesn't mean that it's a bad motivation, but patient groups with registries, observational studies, tissue banks, data aggregators. We talked a little bit about what happens with pharmaceutical things. So these decisions are being made, and patients or subjects or people, or even Google collects our data to come up with Google flu data. So we are already participating in these types of studies, and we are not being consented to them. And I think by putting too many barriers to OHARP-regulated academics, we may be just reinforcing that, because it will continue. The other thing that, as a result of what I just stated, is going to continue to happen is disparities in care are going to widen considerably. So we already know that many of the clinical trials that are done are performed, and this is not bad people, but performed by commercial entities or those who might benefit in the results of those studies. So drug trials, device trials, once those data are collected and get that drug approved into patients, nobody looks at the long-term implication, adverse effects, et cetera. And are those standards of care? I can tell you in cancer, there are very few standards of care because only 25% of patients in cancer benefit from the cancer drugs that they get. So these are some of the things we need to think about as we look at unintended consequences moving forward. The other thing is we can't underestimate the technology and the removal of some of the barriers out there to doing these types of things. So I'll end on it's unreasonable to expect to be able to predict an unreasonable future or risk. But I will tell you that patients do participate in research when you put it in context, and a lot of the context has to do with benefit. And if benefit is new knowledge and acknowledging that we need better treatments and better outcomes, I think we might be going somewhere. So I really appreciate the challenge and the opportunity to present a rhetorical patient perspective, but it really is important, and we need to really look at the realities out there. You can't just look at these guidelines this day at 2 p.m.
Thank you. So we have about an hour as a group to discuss the topic, and the topic here is to consider this notion of what is a reasonably foreseeable risk. I would like to propose to the panel, though, based on the comments that we've had from the panelists and the presenters, where other issues, important issues, have been raised, that we weave some of those issues. For example, should we be carving out the standard of care as a special area, or are we really talking about just research? How does that differ? I would like to see if we can weave some of those discussions together. And the other is, as we talk about risks, I want to just go back to this morning's workshop session on randomization, where randomization might be a risk or might not. I think the message from that was it depends. And there are other types of risks to consider where randomization might actually minimize some of those other types of risks. So I want to just challenge you to think from this morning's session as we consider this topic. And I will make sure that by the end we do address the issues around reasonably foreseeable risk. And Leonard, I think you were ready to go.
Yeah, I just wanted to comment on on whether there should be a separate category of standard of care. And one of the panelists said it should just be called a deviation from usual conduct or something like that, which I don't think is what it is. I think that the intent for doing that matters a lot. So if you are deviating because you think it'll be best for that person, that's different than if you're deviating in order to further the goals of a protocol. What I would suggest is that we don't need the term at all, that it just doesn't matter, that it's research or it's not research, and depending on the risks and the benefits of the research that's proposed, it should be treated like research. But I don't see any advantage at all of sort of carving out this particular area. And for one reason is that it's not really an area, that it covers a whole array of from what kind of bicycle do you use to how much chemotherapy do you get. Those aren't even in the same ballpark. It's just that they're all part of research.
Some of the alternative language to describe the kinds of research we're talking about has been research in usual care settings. So getting around this issue of harking on this issue of standard of care, and that has been helpful to us in thinking through some of the research we've been doing. It's a little more cumbersome and it's not as familiar, and that's why it's unclear why OHRP went this direction of calling it standard of care, but we might make some progress by considering the situation. And I think there is something different about research in usual care settings from the research that's involved with novel interventions. And I think that what we heard this morning was, how does that differ? And I think the problem still exists. I think we have to come up with a better way to name it, characterize it, define it, and share the same language so that we can grapple with the issues associated with it.
Could I ask you, Jeremy, why do you think that that's more clear? Because, like, the Cancer Center is usual care, so I don't know that, what does that specify that?
What I'm trying to get at is that the standard of care thing is clearly, the standard of care has been problematic in research ethics as well for a very long time, right? We haven't settled on standard of care issues about the perinatal transmission trials of HIV, and we're still quibbling over what we meant by standard of care. Was it local or international or global? And it brings up a whole lot of baggage. And I think we have a set of kinds of research projects that take place in usual care settings. Some of those are oncology settings. Some of those are clinical practice settings. Some of those are hospitals in which routine care is given, but at least that's the usual care. So what that does is again, I don't know if it's perfect, and I'm not advancing it as an argument for that should be the preferred term, but it may let us examine the issues at hand rather than get caught up in the other assumptions. Even the different definitions of standard of care that were offered, we weren't given one to work with. Alternatively, we could stipulate a definition, right? Say what we're talking about and go from there. So either solution's fine with me. I don't.
But how does it change the ethical review? I'm sorry.
I heard him.
We need to make sure we have
How
our
does it change?
microphones on and we talk loudly.
How does it change sort of the ethics of reviewing it or the ethics of research by calling it something?
So I think the characteristics of the types of research that we're talking about is research is taking place in the context where there are routine types of disclosure and authorization for a variety of treatments. What's unclear is whether those treatments being delivered are the best, the most appropriate in different settings. Ben gave a quick example this morning about in the context of care. There's several different drugs for treating your condition. This is the one I usually use. Or there are two different drugs. They have, whatever that quick is. And that's deemed to be sufficient for most people in most situations. Or they'll ask questions. They're encouraged to ask questions. And it's not a very elaborated consent model that we're familiar with in research. So I think we have to be sensitive to what are the realities of clinical practice or the usual care settings, whatever they are, and then think about research in that context where we may not need all our entire toolkit of patient protections or research protections in order to, again, make sure that people are appropriately protected in the process, but not overprotected to the point where they're potentially even harmed by it.
Sure. It's just asking you to say a little bit more, Jeremy, about that. I mean, I guess why should we be viewing sort of disclosure standards as being different in that setting? I guess what I'm asking you to say is whether you think that there are activities in the context of research and standard of care settings that you think really are properly viewed as falling under the doctor-patient relationship and not falling under the purview of IRBs and research regulation. I mean, if that's what you're saying, can you say a little bit more about why we should think that?
Sure. So I'm not saying that they ought not be under the purview of IRBs or that the activities, I think that we still need to evaluate the scientific design, the risks, the benefits, equipoise, blah, 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 blah. All of those characteristics are in place. But what we want to be sensitive to is what really happens in practice, right? So the aspirin trial, Rob stepped out of the room so we can talk about it. But if I'm prescribing you aspirin, high dose or low dose aspirin, I may give you an aspirin and say, it'd be a good thing for you to take an aspirin every day. It might prevent some effects of heart disease. Aspirin might, cause you to bleed a little bit more. That's probably about where I was going to stop in clinical practice. If we do a trial and we follow the current guidance to its extreme, let's say we build randomization into that process, do we really need 3 pages of the description of all the risks that have been described to aspirin? I mean, there is an increased risk of gastrointestinal bleeding. There's platelet problems. There's, aspirin hypersensitivity. There are a range of considerations. But people come to that situation knowing a lot about aspirin, right? And so what I'm saying is we don't need to necessarily follow that to its conclusion.
But I don't,
Let me go with
Sure.
Bruce and Don.
no, I just wanted to respond to that.
Yeah, well, I'm going to respond also. I guess you use the term overprotection. The length of a consent form is not overprotection. And even in the clinical setting, if patients are not told about certain side effects, even if they're minor side effects, a patient will worry. My doctor didn't tell me about this, and now I have this minor side effect. One of the things that's often not mentioned is pain, because it's not considered a harm. It's just a discomfort. So these are things that people would want to know, not only in order to decide whether to enroll, but also how to react to a whole array of side effects that might occur that they've never been told about. And if they have been told about them, they're not likely to worry. If they haven't been told about them, they may worry, and then they have to get in touch with the researcher and take a lot of time and effort. So what do you see as overprotection? And let's leave the length of the consent forms out of it, because I don't know what to do about that. But what is overprotection? Not the 3 extra pages.
Okay, so thanks. It's great, and thanks for getting the conversation going late in the day. This is even better than a presentation without PowerPoint. The point of what patients want, let me just take a brief excursus here. What I said was the rhetorically a proxy for patients, right? What patients want and the number of claims, whether we're all patients at times, and our experience as patients drives our understanding and our viewpoint. One of the values of the empirical data we're gathering is to find out what patients want more broadly. And I think before we make claims about what a patient would want or what I would want, we really need to be sensitive to data. And you'll hear more about that this afternoon. That's the advertisement to stay, even though supposedly the weather is still nice, but there's no window. Okay. The second, the issue that you went in, I used overprotection as a placeholder, and it's a poor choice of words. The idea that the numbers of procedures, we only have so many procedures in place, right? Prospective review by an institutional review board could be a good thing, right? If it's doing its job and evaluating risks and benefits and what kind of disclosure mechanisms are there. I think the piece that I'm getting at is we frequently go towards these issues where we get into a habit of disclosing things that are obvious. I really love the rich descriptions in a paragraph to a grown-up to say that you're going to have a blood draw. It's going to hurt. You may bruise. There's a small chance of infection. Look at a 5-year-old. You show them the needle, they run, right? But a grown-up knows that. You're going to have surgery. Will it hurt? If you're in this room, surgery is going to hurt. Right? And so there are certain things, there's a context in which all of this is taking place. And the research we're talking about is trying to be sensitive to the context and trying to overcome some of the inadvertent, unintended consequences of some of what we call protections, and that's what I was trying to say, but did so poorly.
So I just wanted to go back to what a patient expects, and I think in most institutions, they come in seeking clinical care, and we shift the ground, but they don't make that change with us as quickly. And so what patients expect when they come in is not a research study, it's treatment for their condition. So we need to help them make a transition and recognize that the same physician who is going to prescribe a medicine to them, that's what they expected, or whatever they expected, is now suggesting something else. And in that, there does need to be disclosure about that shift from what is usually happening. And so it's not the usual care setting, it's what the patient expects from the physician.
But again, it does depend on the context, right? So we have this sort of Len dichotomized research and treatment, and we talk about more gray within the clinical setting, right? But again, depending on the context, if you look at patient activism, and look at PCORnet, some of the examples, 23andMe, a variety of things where the context may be that patients are driving research. PCORI, patient-driven research. So it's not always the context that the expectation is that, and so we got to be really careful with our general statements about that.
Yeah, I think that regardless of PCORI or patient-driven research, that when we talk about research done in the doctor-patient relationship, that it has to be carefully denoted what's going on. Again, Jeremy, I think that your concern about consent forms that are too long and that we have to really tell everybody all the risks of aspirin is just like, again, a concern unrelated to this particular topic. This is a concern about what you tell people about this, what they need, and it's a general concern. It's not a concern just about this. But would you say that people should be told in the aspirin trial that the reason they're doing the trial is because some people think there's some indication that aspirin reduces the risk of heart attack and fatalities? but that aspirin also increases the risk of stomach bleeding, and that the concern about if you use a lot of it, you may have better results for the heart part, but you may get worse results for the stomach bleeding. Should people know that?
Those general issues, yeah. So,
Yeah, well, those
again,
are the
I'm not
risks.
saying that we shouldn't, what I'm saying is we have one, we basically have typically one model, which is right now, I mean, you're not king yet, or were you king?
I'm
or
working
whatever?
on it,
You're
yeah.
working on it. And then at that point, after your coronation, the world will be a
Right.
better place. But the piece, for lots of reasons, I'm sure, John, not just research in usual care settings. But until that time, we have this one means of doing this. And in clinical practice, those types of situations are handled by an acceptance that many patients come to us with an ability to understand many common treatments and the side effects, that there are other information sources, that we have a conversation, and that all those pieces are still there. Now, if we are doing research and it adds incremental risk, I'm all for it. I'm imprinted on informed consent. I study informed consent. I love informed consent. It's my favorite enzyme. But it's got to be done well, right? And we have to think through how we can do that well, and it should be appropriately tailored to the context. We don't have the latitude, and what the guidance does, I think, and the draft guidance does, is reifies some of the problems we've been dealing with in research ethics rather than trying to address them. And if there is a window to try to begin to improve those problems, this type of research may be a way to do that.
Well, we may never be able to jettison the term standard of care research, but it seems to me our discourse and our thinking will be clearer if whenever possible we avoid that term and talk about usual care research or talk about conventional care or so on. I think it's inherently misleading to patients, if not to us, because it makes it sound like we're mixing unproven and proven therapies.
So this time I'll give a patient example. I don't believe we can overprotect anybody from anything, but I think it's mythical to suggest that we could when we're talking about reasonably foreseeable. And we need to involve patients, I don't know how we aggregate them, but in what matters to be protected from, because we're protecting them from things that, like the monster under the bed in some cases. But I'll give you an example. I'm a cancer patient, so I've been treated for a lot of things, but recently I had something a little bit more mundane. And I was struck by 2 conversations I had with 2 different providers. And one asked me what kind of insurance I had, and then prescribed something. And the second said, this works better, but your insurance company won't provide it. Now, if he had said to me, I would really like to give you this drug if you consent for us to, record it as a research subject, so to speak, I'd have raised my hand. So how do we incentivize this kind of research rather than put the barriers up to it? And maybe I'm just dreaming. That sort of situation. So, because I also think it's a mythical distinction between clinical care and research care. Just because you go to a big academic center doesn't mean you're getting better care than where most people get treated in the community. And those are the people who represent the people that we need to generalize to.
So I want to return us to this really important issue that you all have raised about what the guidance actually says and what's included as reasonably foreseeable based on the way the guidance is written. And so, Leonard, what you said seems to me consistent with the phrase in here: if evaluating a particular risk of research associated with the standard of care is a purpose of the research, then in general, so it's a purpose of the research, then in general, OHRP considers that particular risk to be reasonably foreseeable. That was consistent with what you just said, actually, your interpretation of the aspirin.
Did I interrupt you?
Yeah, no, go
Okay.
go ahead, but then I want to follow on
But that it does say that that's an example of something that's reasonably foreseeable. What it doesn't say is that's it for reasonable foreseeability.
That's exactly
And-
what I want to get
right.
to.
And so I think what the point is of the guidance is that if there's enough question about the risks or the benefits for what we're doing in order to make it a legitimately researchable topic, that the subjects, what's foreseeable, what's reasonably foreseeable is what it is, the outcome is measuring, that's a reasonably foreseeable risk. I think that's right.
That's not dissimilar to, Jeremy, what you were talking about, the sort of reasonable things a physician would share with a patient in discussing treatment options that were part of the standard of care that they might offer a patient, right?
I was struck by Leonard saying he lives in ambiguity, so I didn't know how to understand it, but I think that's right.
Okay, so then my question is then, so there's been this, in our discussion, there's been this concern that reasonably foreseeable could be interpreted to mean any risk that anyone could foresee, right? And that's the basis really of the New England Journal editor's example, where they list everything in the PDR. So is their interpretation, the editor's interpretation, is that a reasonable interpretation of what OHRP meant or should mean, I guess, is the real question. So I just throw that back to you all.
I found the guidance understandable, but I'm a lawyer, and I didn't find it. Yeah, so also I apologize for that. But to me, it did not order or prescribe anything different from what we do on our IRB. And when we have a study that involves comparing different approaches to treatment that have all been, approved or are being used, we have the sections for the risks under each one, but it's nothing like what was in the New England Journal. That was the PDR, that was the drug label. You would never present that. It's classified common, I forget, not uncommon and rare. And if there's a rare risk, a serious risk, you mention that. But a rare, non-serious risk, you don't mention that. I mean, I did not think that was an accurate reflection of what we do on our IRB.
Don't the words reasonably foreseeable appear in the common rule?
Yes.
Yeah.
It's a general
So,
problem.
yeah,
I don't know why.
but, well, it is. I mean, so it's been around for a long time. If we're having trouble with it now, I think it's because there's an underlying dispute or debate going on. Leonard mentioned earlier the word material, and that's much more accurate from the standpoint of what people would want to know. Materiality is that information that will lead a person to decide whether or not to essentially exercise his or her autonomy, to decide whether or not to participate in research. It's surely not all the things that are on the drug label or that are in the PDR or any other place. So reasonably foreseeable, unfortunately, materiality is not an ordinary language term. Neither, for that matter, is reasonably foreseeable, but we're stuck with it because it appeared in the common rule, and that's why we're debating it. But the debate here really should be on what is material to people making a decision. And it's usually not the rarest of the rare. It might be some minimal risks, that minimal risks are always what another person considers minimal and not what the patient or research subject does.
Can I just see, I don't want to push the conversation too far, but I want to see whether there's consensus that if it is a purpose of the study, that it is materially important and should be included in the consent. If it's a purpose of the study to compare some risk, Anyone disagree that, just on this panel, or thoughts about
Question
that?
are all the risks that the comparison will undergo known in advance? No, it's what they're looking at, right?
Right,
but-
but that would be a purpose of the study, right? A predefined purpose. So it might, I mean, I realize that's not probably enough, but is it too much? Because there's some that might think even that's too much.
Well, I mean, it also goes to the benefits. I mean, we have the other term that is alternately used, not the usual care setting, but the comparative effectiveness. And that only addresses effectiveness. But surely, if you're doing comparative effectiveness research, you might also be looking at some of the risks, since that's the other term that's being used to describe this type of research.
So